Good evening and welcome to the special board meeting of November 12th, 2025. We've got a number of issues on the agenda, although primarily this is to discuss next year's health insurance prospects. But first, we're going to start with an update on the auditorium ceiling. Mr. Cashman.
So, as
you want to do attendance or no? Oh, yes, call the roll first. It's not on my agenda.
No, sorry, Matt, didn't mean to interrupt.
that's okay.
Ms. Boucher.
Here.
Ms. Campbell.
Here.
Ms. Hastings.
Here.
Ms. Higgins.
Yep.
Mr. Richards.
Here.
Ms. Robinson is absent. Ms. Sadowski.
Here.
Ms. Walsh.
Here.
And I am here. We have a quorum.
Great.
All right, sorry. Now go
No,
back.
now we will.
Okay.
See, it's not on the agenda.
So, real quick update. Late September, as everybody knows, we noticed the one quarter of the section of the auditorium ceiling where a small 5-inch piece fell. We investigated. We got up there. We made the decision at the time, let's go ahead and do the quarter of this entire ceiling with scaffolding and gain access to it. We brought several engineering firms in, along with Primex. We got a chance to see the entire ceiling from 40 feet up in the air and the scaffolding. And it was at that point that we saw some other areas that looked questionable that had been sagging. So we had been talking internally and with the board a little bit that it's best practice, it's a wise choice to continue going with this process and continue with the demo and fix this the right way. So we've been able to get the engineered report without getting into the weeds, but I can if people want to. 2 layers of 5/8 drywall with fire taping in between. It would be a painted ceiling. There's an awful lot up in the ceiling. Structurally, it's very sound. But the mechanical equipment like the HVAC and the electrical and that sort of thing that complicates this repair job just a little bit. So I think we're going to talk to you a little on the finances and our next steps to go with this project in order to keep it on schedule, which is roughly 2.5 to 3 months from when we officially start. So that's what we're looking at right now.
So what we wanted to do is that we have some information that we need to explain to you in non-public for you to consider before coming back out. Ultimately, you want to vote, but we just want to have a discussion with you based on advice of the attorney. So under that, if you could do it under...
I will make a motion that we go into non-public session under RSA 91A3, Section 2, paragraph J. Is there a second?
Second.
Second by Ms. Boucher. This is a roll call vote. Discussion? No. Ms. Meeker, will you call the roll?
Ms. Boucher.
Yes.
Ms. Campbell.
Yes.
Ms. Hastings.
Yes.
Ms. Higgins.
Yes.
Mr. Richards.
Yes.
Ms. Sadowski.
Yes.
Ms. Walsh.
Yes.
And I am a yes.
And so at this point, we're going to ask Concord TV to pause transmission for a few minutes, and we will be back. What, I think we are back now. We are going to go to our main topic tonight, which is a presentation on health insurance. And then we will discuss and vote further on the auditorium after that. We will likely have another non-public during the health insurance discussion. Dr. Herbert, Mr. Dunn.
You're welcome to come up. Yep. You need your computer to have access to the presentation? Or if you sent me the final, I'll pull it up. Will work?
So,
Yeah,
I
great.
did
You'll
send
be
you the
handouts.
final.
All right, yep, I'll pull it up,
Pull it up.
but we have handouts for everybody,
Yeah,
in case you like paper.
That's my favorite.
And
I
color.
love all of these papers.
Not bound though, just stapled. All right.
Do you want to take a nap?
Nope.
I would like to note that our soon-to-be new board member-elect Manal is joining us.
Yeah. Welcome, welcome.
Which may run short.
So we will get to a section in this presentation that already has the non-public information on it.
Could you take a moment to introduce yourself?
Good evening. My name is Kirsty Carpage, and I'm with Borslow Insurance, and we are consultants that work with the Concord School District on your benefits, employee benefits.
Kirsty's
So-
worked with us for 13 plus years, so, yeah.
And we work with a number of municipalities and SAUs throughout, in the state and throughout New England. Tonight, we are going to, go through a number of things. We're gonna start with we won't spend a ton of time on trends, because I was here earlier and we went through that, so we don't need to go into great detail on that. Then we can talk, we wanted to spend some time on Concord claims and where your plan is and how it's running. Talk a bit about the school care pool renewal, talk about your renewal, and then talk about the potential to issue an RFP and all of the different options that are out there, okay? So, if you go to the next slide. So just to reiterate, we're all living through a really interesting time, and we really haven't seen medical or prescription drug claims this high in the 20-plus years that I've been doing this. And so it really doesn't matter what state you're in, whether you're public, whether you're private, whether you're large, whether you're small, whether you're self-funded, fully insured, in a pool, not in a pool, you are all of us are subject to these really high prescription drug costs and really high hospital costs. And in New England, the trends are even higher than what we're seeing nationally. Nationally, we're seeing an average of 9% on medical and 11% on prescription drugs. And if you go to the next slide, and we showed this last time, this is the range in New England. And when I did this slide, I was using every single carrier, every pool, just to try to make sure that everyone was represented. But these are the ranges that we're seeing. For the January renewal cycle, which is what we're just finishing now, so many groups, so many trends that are 10 to 14% and renewals in the teens and 20s for big, large employers. So that's very common right now. Go to the next slide. So this is actually a new slide. This is the Kaiser Family Foundation. So there's a few organizations that come out with annual surveys, and they survey like hundreds and hundreds of employers across the United States. But it just gets to what's, again, driving the increases, prescription drug prices, chronic disease, higher utilization, the higher hospital prices, which we're really seeing consistently, and then coverage for new prescription drugs. You go to the next one. And I just put this in because I thought this was really interesting. This is another Kaiser slide, but so what it does is the blue is inflation from 2015 to 25. The black is earnings. And then the orange are insurance premiums, and the yellow are deductibles. And you can just see how premiums and deductibles are increasing at a faster rate than wages and inflation. Okay, so now we're going to get into Concord claims. So we can go to the next slide. Okay, so this is a Cigna report. Call it the CAP report, and it's run for 12, it's always year over year, so 12 months over 12 months. So it's 12 months between July 24 and June 25 versus the prior 12 months. And you actually ran pretty darn well. So your overall employer paid increase for those 12 months was 4.6% increase. And you can see that the prescription drugs clipped up much higher than the medical, so the prescription drugs were running at plus 17. You can go to the next slide. So this one is by relationship, so employee, spouse, or dependents. And so by relationship, spouses incurred a much higher per member cost than employees. And spouses were up 22%, employees were up 13%, dependents were down. When you take the catastrophic claims out, those are the high-cost claims, then employees were the most expensive just by a bit.
It looks like employees are down 0.6.
Employees are down, but they're a little bit more expensive than the spouses.
okay.
Yeah. So then we asked, like, well, where are the drivers? So specialty RX is definitely a driver. That's up 36.2%. Those are like the things that you see on TV at night, all of the jingles, all of those Stellaras, Humeras, et ceteras. You can see a direct correlation, honestly, in claims across the board, not just here, everywhere, between the ones that are advertised and then the ones you see in the claims. It's really common.
And do we have restrictions on specialty? What does our plan cover, and what is the copay for?
Yeah, so, well, you have different plans, so it depends on the plan, the yellow plan or the orange plan. It's not a copay.
Yeah.
But there is a program called Save On that school care employs, which is really smart, and it allows them to capture the manufacturer coupons and apply them to the overall cost, reducing the plan costs and making the cost for the member, sometimes zero. It was a couple years ago when they implemented that, and we saw this huge kind of decrease in the overall cost of the prescriptions, but you don't get the decrease every year. You kind of like move down to a new level because most people that are eligible for Save On are on it, and now we're just kind of whoever, there's a few new ones each year. But it is a good program to have in place, and it is in place.
Ms. Boucher, Ms. Sadowski, but you didn't really answer my question
That was
about what our restrictions are around specialty drugs. And you can use the yellow, because that's where most of our employees are.
Well, they're not treated any differently from a coverage standpoint. It doesn't cost more or less, like the 10% coinsurance for a prescription up to the deductible. It isn't, whether you're on a specialty drug or you're a regular drug, it wouldn't.
So we have no differentiation between generic, brand name, and
Well, the
specialty?
drug would cost more.
Right.
It's 10% of a higher cost.
Okay, so they pay 10% on
Yeah.
everything. Okay,
Yeah.
thank you. Ms. Boucher?
The savings that school care then receives, correct, using, is it called Save On? Mm-hmm. Where does that savings go?
It goes back to the plan. So so it would be like a decrement on your claims.
Okay,
So
so
like,
it's a
you
way
know
to
how-
reduce the total claims.
Yeah, it reduces the overall claim
Okay.
cost, yeah.
Ms. Sadowski?
So there are no drugs that we don't we cover all of the drugs advertised on TV? then?
So Cigna would have a formulary, right? And so they would have a formulary that I would say that most of the drugs that you see advertised on TV are covered. I mean, you have a very comprehensive formulary. It's not, there's prior authorization, so a doctor would have to say that this person qualifies and why they qualify, but, you have a very open, comprehensive formulary that covers a lot of drugs.
Other questions? Go ahead, thanks.
Keep going? Okay, so trend, your medical increases were driven by either high-cost claims, which here they call them catastrophic claims, or pharmacy. Those are the two areas. You can go to the next slide. So then what was driving it, what conditions? Primarily, the top two were musculoskeletal and cancer. And that is very common to be seeing musculoskeletal and cancer in the top two. You can go to the next slide. So the musculoskeletal was primarily driven by outpatient procedures, which is something that we see a lot of times. If you get a hip done, they send you home, right? You go to the surgical center and it's done in a day, so a lot's done outpatient these days. So it's not surprising that if you had a really high musculoskeletal incurrence, then you'd have high outpatient. And then pharmacy. So this is a prescription drug slide. So we kind of were talking before that the employer paid was up 17.5%. If we go down, we can see the generic dispensing rate kind of in the middle, and your generic utilization. So you have really good generic utilization. There's nothing like glaring here other than that you have a really high specialty pharmacy. So if you go down to the bottom of the gray, you can see that specialty pharmacy was up 36.2%, and that's definitely a driver of your costs.
Simple answer, what's specialty pharmacy?
So specialty are kind of the highest cost drugs. So there's generic, and then there's brand, and then there's specialty, and it's like a very fast growing category, because what's happened is, say 10 years ago, a lot of conditions maybe that now are treated with prescription drugs used to be treated maybe in an inpatient manner, maybe they weren't able to be treated, but there's just such innovation on the pharmaceutical side. So Keytruda, like you can keep people alive when they've had cancer for a much longer period of time, or you can have people with MS working great long, careers now because there are prescription drugs that help that,
Right.
So a huge category, which we're going to see, are these anti-inflammatories that, like psoriatic arthritis, and so Humira, Stelara, colitis, Crohn's disease. There's all these conditions now that are being treated with these drugs, and people to great success from a clinical standpoint, but to great cost from a health plan standpoint. And so when we look at claims now, it's just this much bigger portion of the claim overall than it used to be.
Well, it sounds like it's a redefinition of pharmaceuticals. Usually those were for a little while. Like you have a procedure, you take a
Right.
little while, or
Yeah.
you get sick, you take a drug, and then most of the time you're not taking anything. And now most people walk around with a suitcase.
There's a lot more, so many more conditions. Or like when we look at the high-cost claim reports, it'll be, sizable. Like sometimes half will be people just the drugs. Like you could have $1 million claim and it's just the drugs.
Right.
No medical.
Right.
That's
Right.
that we didn't used to see that, but we see that a lot now. So it's just a growing category.
Yeah.
And there's specialty drugs that are through the pharmacy, which is what we're talking about here. And then there's medical specialty drugs, and those are drugs that come through the medical claim. So there's two different categories of specialty drugs because they're being used so much to treat things now.
So a chronic illness that you maintain health, like I have asthma, so I have one very expensive inhaler. If I had to buy it, it's like $550 for one inhaler,
Yeah.
which is prohibitive, but I have to have it. So that's a chronic illness maintenance, so that would be specialty pharmacy, not medical pharmacy?
That would be, yeah, that would be specialty pharmacy at the.
So give me an
Anything
example.
you get from the pharmacy.
Yeah. So give me an example of medical pharmacy.
Medical pharmacy would be like an infusion. You had
Okay.
a
Yep, yep.
child with a pretty serious condition. A lot of times there's, like, I don't know, muscular dystrophy,
Yeah.
something like that. And there's like, so that could go. It depends. But when you get things done in the hospital or in a hospital setting.
But you have to go to a hospital setting to have the medicine given. Okay, thank you.
So these were the top therapeutic classes that you had. So anti-inflammatory, which we see all the time. So again, the arthritis, the psoriatic arthritis, like those kind of autoimmune type things. And then asthma, we've got hypoglycemics, and then the psoriasis again, diabetes, antidepressants, things that, so cancer, MS. So these are very, very common. This is very similar patterns that we see. So your top were the anti-inflammatories. And then if you go to the next slide. So these are the drugs, actual names of different drugs, and then you can see. So that's where I'm talking about, like the Humiras and the Stellaras and those type of things. And then you've got some cancer drugs. Okay, so let's talk about school care for a bit here. So in the school care pool itself, for this time period, the same time period that we were just looking at, where you were up 4.6, they were up 13.3. In the most recent pool, in 2024, 2025, they thought it was going to be 7, but claims skyrocketed up to 13.3. And those higher claims were driven by, same as you, high cost claims and pharmacy, like very similar patterns. So the pharmacy rebates, so pharmacy rebates are the pharmaceutical manufacturers will actually pay plans to put their drugs on their formulary, and they will give rebates back. So they actually give incentives back to put the drug on the formulary. And so those rebates go back to the plan. So if you're running a self-funded plan, you pay for all the drugs, and then the rebates, it comes in arrears like a couple quarters later. They'll come back. You get these rebate checks coming back. So school care, the rebates were about 33% below where they thought they were going to be. Part of that can be due to mix. You never know who's going to be on what drugs. So you forecast that the rebates are going to be a certain amount, but then maybe people aren't on that drug anymore. Maybe they got, maybe now they're on a biosimilar. So we've seen this, like with Humira, there's a biosimilar available now. So the drug costs less, but you don't get the rebate back, right? Because you're not on Humira anymore. So less. So their rebates came in 33% lower than they thought because of more generic and biosimilar utilization, or specialty meds that new people got prescribed that weren't eligible for rebates. So anyway, as a result of all that, the reserves were very low on June 30th, and they had a projected deficit of $4.5 million, and basically the board concluded that it was due to the unprecedented claims, and that they expected that trend to continue.
Should they use a PBM?
He-
Pharmacy benefit manager. I'm sorry.
Yeah. So it's within Cigna. I know, it's the Cigna PBM. It's not like a separate outside PBM.
Okay.
Yeah.
I just know there have been some critiques around PBMs and that the rebate strategies aren't always in the best interest of the customers or even the clients, but they do well for the PBMs.
Yeah, I know. So it's like so sometimes if you have, like, do you want to have more higher cost meds so you get the rebate, or do you want to have lower cost meds with no rebate, right? And so rebates are kind of a funny animal. But I do think that if you go to the next slide, one of the things that School Care did is they negotiated, or maybe, well, it's going to be 2 slides in it from now, but they negotiated a better rebate mix with Cigna. So it is something where you are literally, like, Cigna is in business, right? As are all of the pharmacy benefit managers or all of the carriers. And so it is a negotiation of, like, how much of those rebates are they going to give back that they're getting, right? So, and so there's that, and then there's what actually will the drug mix be and what will the rebates be in the future. So it's kind of double-edged sword.
Ms. Boucher?
How is school care utilizing care coordination in terms in
Yeah, so
reducing
Cigna has
costs?
So they do have significant care coordinate, like case management and care coordination in place, and and it's all administered through Cigna. I think they do an exceptional job of trying to get people into care coordination if they have complex conditions or if they have like a serious medical surgery or something that's super complicated or something where you can help people navigate the system to higher quality care so that they can get something done well right up front. So I don't feel like the area of opportunity would be more care coordination. I do feel like there's an area of opportunity in helping people understand where to go to get higher quality, lower cost care. So I think that that's
who would
something
be responsible for that, not care coordination?
What's that?
Who are you saying would be responsible for that, the educational opportunity you're just mentioning?
So I am hopeful that School Care and Cigna are going to lean into trying to give people more tools in order to try to figure out where you can go to get these outpatient surgeries.
Not just care coordination. because
Not
you're
just care
saying-
coordination, but more like, because they're in New Hampshire, there's such a discrepancy in cost between like, if you got a hospital and a surgery
Price
in a hospital
transparency.
versus an ambulatory
You're
surgical
talking about
center.
more price transparency.
Yeah, more price transparency, and the ability for people to know that and access that. So I think that they're going to try to lean into that more, which I think is an opportunity.
Well, and some of that the state needs to require that.
There's just, I think it's one of the biggest challenges of trying to navigate the healthcare system, right? Like that there is such a wide disparity in cost, and how do you know? How is the average person at the point of service supposed to know where to go?
And
I might have
what did
thoughts
your
on this,
health
yeah.
plan negotiate versus what did someone else?
Yeah.
Like the price isn't the same at every
No.
facility for every person, so that's.
Isn't that
always-
crazy?
It's like an
Or
airline
even
seat.
Whether you have a
Dynamic
PPO or an
pricing.
HMO, or whether you walk in the door with this plan or that plan, it's all differently negotiated, but there's an opportunity here. We have technology, and like this is something that needs to be solved because. So I think that is a big opportunity for school care. I think they're going to start leaning into it because.
As in, they would be the ones to have that price transparency.
Yeah,
They're
they
the
would have
ones
to work
that-
with Cigna in order to try to deliver that.
I mean, is that part of the prior authorization process?
Nope.
And should it be to say, okay, but you can have this surgery in an outpatient facility?
Well, the thing is with prior auth, so prior auth would be more, say it's a back surgery, is this surgery right for you? Is this the right procedure? So that's more prior auth to get like the approval for the procedure, but then where it is isn't usually prior auth. Like, cause then like the same surgeon could be operating in an ambulatory surgical center or at a hospital. Happens all the time. So you never really get the prior auth for the place. We have freedom. Like we can go where we want. Like we aren't really restricted on most plans that you have to go to a certain place. You have choice, but choice comes with a cost, right? So
And is it a higher cost for how does it, I have a certain copay and co-insurance rate for an outpatient facility versus an inpatient facility. Is that the same as?
So it depends on the plan design. So
Well, our yellow plan.
So the yellow plan isn't structured like that. It's structured like you pay, there's consumerism up front because you see how much something costs, but once you've met your deductible, you're done. Your out-of-pocket max, once you've met your out-of-pocket max, right?
And what is the out-of-pocket max on our plan?
So 2,000 for an individual and 4 for a family, but if you take the choice fund, then it's 1,000, 2,000.
Any other questions? You can go on.
So, okay, let's see. So this is just going a little bit more into the school care pool. So the operating loss was 25 million as of June 30th. The high cost claims were up 18%. The GLP-1s for diabetes topped 5 million. It wasn't for weight loss, it was just for diabetes. So after the actuarial adjustments, the reserves stood at 4.5 million. They needed 34 million, hence the 30 million assessment. Then the question was what trend was going to be put into the renewals for the upcoming cycle. And so they decided that first we have the rate increases. So the rate increases for the upcoming cycle ranged from 7.8 at the low end to 34.8 at the high, with the average being 17.3. You came in, we'll see this in a bit, at about 10.2, so at the lower end of that range. And when you move to the 2.0 plans, it went down to, like the 6% range. So you're at the very low end of this school care range. You had the 4.6% increase versus their 13, so it made sense that you were going to be at the low end of the range. But then there was also what trend were they going to use moving forward? So the board approved a 9.4% blended medical trend. They added another 1% to claims margin, and then a 0.8 to rebuild contingent reserves. So the trend they're using for the upcoming renewals is 11.24%. Which is very in keeping. What?
That's up from 7 the last 2 years.
Yeah, that's up from 7. That's very in keeping with what we're seeing in the market, to be honest. So this is what I was getting to, the $6 million in value through contractual enhancements, pharmacy discount improvements, health management program enhancements, administrative fee reductions, pharmacy rebate enhancements. So they basically went back to Cigna and renegotiated terms. And then they changed the relativity, so you'll see like your orange plan increased more than the yellow plan to try to keep up with kind of like the claims trends for the different plan designs. And then they're introducing the new 2.0 plans, which have the higher deductible as of July 126, or when the CBA's, the bargaining period expires, then it would move to the new higher deductible plan. So this is you. So you ended the year with a loss ratio at 100. That means for every dollar you paid into school care paid $1 in claims, whereas the prior year for every dollar you paid school care, they paid $1.03 in claims. So they run super lean, but there has to be a little margin to manage the program, right? So there was no margin for the past 2 years for Concord. We did see at the last few months of the plan year, the loss ratio started to tick up. So like March was 108, April was 144, May was 133, June was 109. So those are high, right? So it did average out for the year at 100.49, but we did see an uptick towards the end of the year. And then as far as the high cost claimants, so the ones over 150,000, in 2024, 2025, there were 10, totaling 2.8 million, 2 termed from the plan. The prior year, there were 8, totaling 1.9 million, 1 in term from the plan. And then at the bottom, I was just putting how large, you know, you have 586 subscribers and 1,415 total family members on the plan.
Questions? Seeing none, I will move we go into non-public session under 91A2, section 1, paragraph A, strategy or negotiations with respect to collective bargaining, and section 2, paragraph C, matters which if discussed in public would likely affect adversely the reputation of any person other than a member of the public body
Should I give that to
itself.
her or not?
What's that?
The next section?
I'll let
or
them
not?
finish and then we can talk about that.
Is there a second?
Second.
Second by Ms. Sadowski. Discussion. This is a roll call vote. Ms. Meeker, will you call the roll?
Ms. Boucher?
Yes.
Ms. Campbell?
Yes.
Ms. Hastings?
Yes.
Ms. Higgins?
Yep.
Mr. Richards?
Yes.
Ms. Robinson? Just kidding. Ms. Sadowski?
Yes.
Ms. Walsh?
Yes.
And I'm a yes.
Okay, so does he know?
Yep, Ms.
Hastings,
Hastings.
seconded by Ms. Boucher. This is a roll call vote. Ms. Meeker, will you call the roll?
Ms. Boucher.
Yes.
Ms. Campbell.
Yes.
Ms. Hastings.
Yes.
Ms. Higgins.
Yes.
Mr. Richards.
Yes.
Ms. Sadowski.
Yes.
Ms. Walsh.
Yes.
And I am a yes.
Great. We are going to go back to Concord High School auditorium. The Can we just get a little summary of where we are in terms of ongoing costs and what the administration is who is paying those costs and what the administration is suggesting for a solution and asking for in a vote moving forward?
Do you need me to say what I believe? We got the first portion of the ceiling was $110,000. And that's the scaffolding and to repair that part. That was the first quote we got, and that's what triggered it, because they had to get up there to see it. Once they got up there on the ceiling, they realized that the ceiling was coming down, the whole ceiling is coming down. So now that amount has expanded. Our insurance carrier originally was gonna cover that part. Now that they see it's all interconnected, we strongly believe they're gonna be covering the entirety of it. We are at about $35,000 a month for scaffolding. The rest of the scaffolding has been brought in to cover the whole room and to get up into there. So every month that goes by, that is a cost that is being accrued. We do have Primex involved in this, but that is where it's at the moment. This will likely expand to over $500,000 easily, if not more. So that's where it stands at the moment. If we were to stop, the scaffolding is $35,000 a month to sit, and there is no activity. That is shut off. It's not like, oh, you just can't go in that section. That whole room is off limits, cannot be used, the whole auditorium. So I think I could cover what you
So
asked.
the request to the board is that you have gone out and spoken to contractors and got them in to do the initial review, and you are requesting of the board that we waive the bidding process in this because you believe that would be in the best financial interest of the district
And the education.
and the education of students.
I move that we accept Jack's suggestion.
I'm going to open the public comment
Oh,
period
first?
first before
That
we
sounds-
vote.
that sounds good.
And then, but I wanted to give an opportunity if there are any other questions or discussion. I do have on where we are putting other art programs or other theater programs during this time. I've heard some concerns about using the band room as for the senior one acts. I'm wondering if we can do a little better than that.
We offered to assist with doing better, and we were told for the time it would take to move the equipment and set up for what they have to do for the senior one acts, that would be counterproductive. That I would, when speaking with the advisors, this is what they thought was the best solution.
And how many people can see the senior one acts compared to normally would from the band room versus the theater
We
versus Beaver Meadow?
I think we can fit about 200 people in there. We do staff meetings of about 130 in there at a time, and we have room in there. We're still within code.
Those don't tend to fill the auditorium. But I also think it's the job of those people they're the ones that are in doing it, like it's not a board decision to dictate where they go.
No, but we can
did
ask
look-
questions.
We did look at other options in the district, and it would involve over 2 weeks of cancellations of PE classes to hold it in the place that was a desirable location by the club. Unfortunately, 2 weeks of lost instruction and a teacher not having access to their classroom with no compromise in there just wasn't an option for the building that
Okay.
we were looking at.
Thank you.
Oh, yeah, right.
Okay, other questions, comments? All right, I am going to open for our public comment period. Seeing no one here, I'm going to close our public comment period and once again thank the legislature for our theater of the absurd. Ms. Higgins, you had a motion.
Yes. My motion is to approve the suggestions of Jack, which we've talked now, and I don't remember exactly what he said, but essentially to grant the,
To
Matt,
waive policy
policy, thank you.
322 to allow the district to directly contract.
Yes, without,
Without
foregoing the bidding
bidding.
process, yeah. I think this situation warrants it.
Thank
And I
you.
would, point of clarification, it's not actually waiving the policy, it's adhering to the waiver in policy
policy,
322,
yes.
section 2, that allows for the waiver of the bidding process when it is in the best interest of the district. I think we have heard tonight that we have cost issues, we have educational issues, so I do think that I agree with, Barb's motion, that I actually think it adheres to our bidding policy well.
Is there a second?
Second.
Second by Ms. Boucher. Further discussion? Mr. Richards?
Yes, I don't typically like to waive or to utilize item number 3 in the policy, although it is fully within our policy to do so. But in this case, I think it serves not only the students but the taxpayers as well because of the cost incurred by ongoing scaffolding. So I support this.
Any other discussion? Hearing none, all those in favor?
Aye.
Any opposed? Any abstentions? Motion carries.
Good luck, Matt.
Yeah,
Thank you,
if I
Matt.
could,
Thank you,
if I could
Matt.
just comment too, I mean, Matt was on that very quick, and that was one of those things that you get up there, try to take care of it, and you realize it's a much bigger job than, it was not expected at all. And now, the money clock's running. So to back up is just, it's hard, because now you're impacting all these programs, and I can't imagine taking that scaffolding down, because we're not going with that. I mean, it's,
Right, we're in
if
it
you've
now.
seen the picture,
So
it's,
I do think it's important, and the purpose of our non-public discussion was to discuss the cost of the work from the contractor we have been working with on this. Now that we have decided to go with them, that is no longer non-public information. So I think if you want to just discuss a little bit who's going to be doing the work and the expected cost and the cost process, that would be good.
So Harvey Construction was the first group I called in because it was a complicated project and it was tough to get to. So with that, there were other contractors, a scaffolding contractor, a drywall, a demolition contractor. I'm trying to,
So your plan
I'm-
is to go with Harvey Construction for an estimated cost of,
$751,044.
thank you, which the majority of which we expect to be covered by our insurance company.
and I say majority just because in case there's some incidentals that all of a sudden come up. And we are gonna work at a cost-plus model on this, so it's not a lump sum. We will be able to track those costs and be involved with that as well. Okay?
And Mr. Dunn, this is the defined scope of this project. Any extension of the scope or additional scope would come back to this board for its review.
I guess if the scope changed extensively, like if they're up there and they find something, insurance, they consult with insurance, yeah.
Right.
If all of a sudden we're
Significant.
gonna move now to a drop ceiling and there's gonna be expenses, there's acoustics, that they say, well, this is now more obvious, yeah, or anything else you wanna see.
Significant
Yeah,
changes in
if
scope.
that's okay, and, I mean, we can bring everything back, or report up to you, that's not a problem.
Significant changes in
Yeah,
scope. I
okay.
would be concerned on if,
Yeah.
once involved in this project, it was decided to replace all of the lighting or
Yeah.
to change some structural item, I would want it to come back to this board.
Because as of now, I don't think the rest of the ceiling's down yet, because they haven't
No,
started
they're gonna-
that, so.
they're gonna begin
yeah,
that shortly.
What's gonna be beyond that ceiling, true, if there's something that comes up, but obviously, we'll update you, and then we're in constant contact with the representative from Primex, so, yeah.
Okay.
Ms. Meeker?
I do have a request of the district, if there's time, from our communications director, because this is something that's going to garner a lot of public interest. and people are gonna have questions about timeline, about cost, about insurance, about the waiver of the bidding process. Is there a way that we, and we had a public, then a non-public, then a public, if there's a way that we could craft a statement on this, how we came to where we are right now, and sort of the general timeline, I think that would be really helpful, because then we can just point people to it.
I was just gonna ask Matt for a good photo. He likes to take good photos.
He does
and
take
share
good
them.
photos,
So
yeah.
I
Although
think-
it is really hard, because Matt took me
Yeah.
up there, and the photos he showed, it's really hard to see from the photos
perspective,
how
yeah.
bad
Yeah,
the,
Boeing is.
The
Boeing is.
scaffolding is impressive.
yes, the
Like,
scaffolding
yeah,
is
so,
impressive.
Yeah, we can definitely, I was thinking we would do a news article that's right on the homepage and we can link to it.
Yep, great.
So, a one sentence blurb for people that only wanna know that, and then a little longer article that includes the.
But I also think in the superintendent's update, because there's gonna be a lot of interest in when
Yeah.
the
Shows
auditorium will
are-
be available for use again.
Pam will wanna know.
And,
The other Pam.
Yes.
The other
She'll
Pam
wanna
will
know.
definitely wanna know.
and Matt, or it could go to the superintendent either. This auditorium is fully not being used, or it's fully non-functional at this point, and no one is allowed in there?
Yep, completely off limits. We have it posted, we put out messaging to the school, and doors are locked. We're being very, very diligent about that.
From a safety point of view, I think that's,
Absolutely.
Thank you.
Okay, with that, I'm going to make a motion that we go into our third non-public of the night. I do not expect that we will come back except to adjourn after this one, which I move that we go into non-public session under 91
Second.
A3, Section 2, to
Easy
discuss
there, Karen.
personnel matters.
And Liz
Second,
Boucher's like-
seconded by Ms. Boucher. This is a roll call vote.
Oh, goodness.
Yes.
Ms. Boucher.
Yes.
Ms. Campbell.
Yes.
Ms. Hastings.
Yes.
Ms. Higgins.
Yes.
Mr. Richards.
Yes.
Ms. Sadowski.
Yes.
Ms. Walsh.
Yes.
And I am a yes.
Great.
We're non-public.
So we will be not coming back on Concord TV this
Boy, the
evening.
trees that
Thank
die
you.
on these